Good morning. My name is Susan Stellan. I'll introduce myself shortly, but as you join the webinar today, just going to ask you to open the chat box, which we'll be using, and please introduce yourself, where your name, where you're located, and your role or connection to this topic. And we'll give people a couple minutes to join before we get started. And we will be using the chat a bit throughout the workshop today. So if you leave that open, I'll have some questions that you can respond to that way. Great, see a few introductions coming in. And I'll just repeat, as you're joining today, if you could add your name to the chat with where you're joining us from today, the organization or role you're in, that's really helpful to see who's here. We'd see a range of people joining from different places, kind of different roles. Definitely some I recognize. I see a Michigander here. I grew up in Michigan. Great. TC, Michigan. Know that place too. All right, I'm just gonna repost that message, reminding people to add their name to the chat as you join today. And I'm going to turn this over to Kati, who's gonna go over just a few introductory slides.
Thank you, Susan. And good morning, everyone. And thank you for joining us for our webinar today, Understanding Addiction and Options for Care. This webinar will be provided by Susan Stellan, public health researcher, educator, and communications consultant. Next slide, please. This webinar is sponsored by the Northeast and Caribbean Mental Health Technology Transfer Center, or MHTTC. We're housed at Rutgers at the School of Health Professions in the Department of Psychiatric Rehabilitation and Counseling Professions. My name is Kati, and I'm the project coordinator of the center, and I'll be introducing going over our center this morning very briefly. Next slide, please. Just as a note, the recording will be posted on our website within 7 days, along with the presentation slides. And you will also receive a certificate of completion within those 7 days. So throughout this webinar, we ask that you please use the chat feature. If you'd like to speak, I can enable your microphone if you use the raise hand function, and then I will go over and enable your microphone as you wish. Next slide, please. Just as a reminder, this presentation was prepared for the Northeast and Caribbean Mental Health Technology Transfer Center under a cooperative agreement from the Substance Abuse and Mental Health Services Administration. All material appearing in this presentation, except that taken directly from copyrighted sources, is in the public domain and may be reproduced or copied without permission from SAMHSA or the authors. Citation of the source is appreciated. So we ask that you not reproduce or distribute this presentation for a fee without written authorization from the Northeast and Caribbean Mental Health Technology Transfer Center. As a reminder, the MHTTC network uses affirming, respectful, and recovery-oriented language in all of our activities. And this is language that is strength-based and hopeful, language that is inclusive and accepting of diverse cultures, genders, perspectives, and experiences, language that is healing-centered and trauma-responsive, and invites individuals to participate in their own journeys, language that is person-first and free of labels, is non-judgmental and avoids assumptions, is respectful, clear, and understandable, and consistent with our actions, policies, and products. So now I will turn it over to Susan so she can also introduce herself.
Thank you, Kati. So just to repeat, my name is Susan Stellan, and just to share a little bit about how I came to this topic. Spent most of my career in journalism and teaching media ethics, and went back to school to study public health in 2017. Since about 2019, I've been working on projects to reduce overdose deaths, educate people about substance use disorders, improve access to treatment and harm reduction services, and support people in recovery. And I've been facilitating training workshops on all these topics and really try to present a wide range of perspectives. I often collaborate with my husband, Graham McIndoe, a photographer who's been open about his history of addiction, incarceration, and recovery. So that really informs kind of how I ended up focusing on this topic, as well as you'll see, I try to take a visual approach to learning and kind of really taking things out of research and academia and presenting them in an accessible way to a wide variety of audiences. So you just see a couple of pictures here of some work we've done around exhibitions or public art, broadly in these two examples about recovery, as well as ways to reduce overdose deaths. So I'm just going to repeat in the chat here. If you're just joining us, please add your name to the chat and where you're joining us from today, and your role really helps us get to know who's here and kind of shape the discussion today. So as Kati mentioned, the title of this workshop is Understanding Addiction and Options for Care. This is the fourth in a series of workshops. So, we've talked about harm reduction, we've talked about, current risks in the drug supply, and kind of moving on to, broadly treatment, or treatment broadly defined, and then options for care. So at the beginning, we're just going to review a couple things, some data sources about substance use disorders, the treatment gap and barriers to care, how person-centered trauma-informed care can help increase treatment engagement and outcomes, overview of medications for opioid use disorder. We'll talk about contingency management for stimulant use disorders, resources to find treatment services and questions to consider for referrals, and peer support and mutual aid. So just want to reiterate, please use the chat to post any questions, comments, trying to stay within the topic we're on currently, or if you have any questions regarding what I've discussed. And as Kati mentioned, if you raise your hand and you're in a place where you feel comfortable speaking, please do that. And there will be some kind of questions for all of you throughout the workshop today. So just want to start out with, this definition from SAMHSA about how a substance use disorder is defined as we start talking about treatment or care for people with substance use challenges. So substance use disorders occur when the recurrent use of alcohol and/or drugs causes clinically significant impairment, including health problems, disability, and failure to meet major responsibilities at work, school, or home. So in the previous workshop, we talked about some of the criteria used to diagnose a substance use disorder. There are 11 criteria, and they're sometimes presented in 4 kind of broad categories. So just opening it up for a question, what are some of the criteria used to diagnose a substance use disorder? And feel free to raise your hand if you're somewhere you feel comfortable speaking. You don't have to get all 11 or, but what are a few? Okay, I start seeing some responses. So craving or urges to use substance is great. Thank you. What else? Amount of use, impact on life, tolerance, yeah, inability to stop despite consequences. Great, wanting to stop and not being able to, going through withdrawal, certainly for some substances, using more than planned. Great. And those consequences, the impact it's having, right? So, important as we start talking about treatment is kind of figuring out who among the larger group of people who use substances might benefit from treatment or other services. So this is a bit of a review here. So, I won't read everything on this slide, but broadly, the first 4 fit under this, category of loss of control. So some of the things that have been mentioned, using more than you intend or more frequently than you intend. So that might be intending to just drink or use substances on the weekend, but then it's happening midweek or during the week as well. Trying to stop or cut back and not being able to, spending a lot of time, obtaining, using, or recovering from substances, and then that craving that's been mentioned. The second category are these interpersonal consequences. So it starts impacting, your obligations at work, school, or home, or, the other responsibilities you have in the community. And then continuing to use even though, it's causing these interpersonal problems. And then maybe skipping activities, missing work during a day, or not meeting friends because of substance use, or maybe, hangover, recovery the next day. The second category, or the next slide shows, these other two categories, and one being risky use. So that might be using recurrently in physically unsafe situations. So, that might be driving under the influence, whether that's of alcohol or other drugs. And, continuing to use even though that's starting to cause physical or psychological problems. And then that last one, physical dependence. So that tolerance, needing more of a substance to achieve the desired effect, or experiencing withdrawal symptoms after quitting or reducing use. That's for some substances, certainly opioids and alcohol would fit into that. There's a kind of a note here noting that, if you're receiving, for example, medications for cancer treatment, you would experience withdrawal if those were stopped, and you would have tolerance, but that doesn't count as a criteria for a substance use disorder. Important to note too here that substance use disorders fall into these different categories of mild. So if someone meets 2 or 3 criteria, moderate, 4 to 5, or severe, 6 or more. So, there could be a real difference between these people, someone who's on that, 1 or 2 or 3 versus 6 or more. And, that moderate tipping into severe would be what's kind of popularly understood as addiction. But thinking kind of more broadly, I also have shown this slide that, this is from the National Survey on Drug Use and Health, the percentage of the population 12 or older, this includes alcohol, that meet the criteria through the survey. Again, that's not a clinical diagnosis necessarily, but of a past year substance use disorder is about 17.3% of the population, 12 or older. So on the right here, you see the bars for, at the top, alcohol use disorder, and then broadly drug use disorder, as well as, specific substances there. So, you can see that marijuana use disorder certainly impacts many more people than, for example, heroin use disorder at the bottom there. But these categories are not mutually exclusive. So, depending on how someone responds to these survey questions, they might fit into more than one category. And this is a graphic SAMHSA puts out that shows, the severity level. And, you can see that the most common is a mild substance use disorder. So if you're looking on the right there, that would be about 55% of people with any substance use disorder. It would mean or meet the criteria for a mild substance use disorder, versus about just under 23% for moderate and about 22% for severe. So, that kind of puts in context that, that 17.3% number, half of those would be considered a mild substance use disorder, and relevant for kind of thinking about treatment or specialized treatment, or what type of care someone might benefit from, and as well as the harm reduction services that were covered in a previous session. So, using that full category of people who meet the criteria for any substance use disorder, the National Survey on Drug Use and Health identified a need for substance use treatment in the past year among people aged 12 or older at just a little over 19%. So that does include people in that mild category. So that's defined as having a substance use disorder in the past year or receiving substance use treatment in the past year. And feel free, if you have any questions, to post those in the chat or raise your hand. And this is the percentage of people who, met the criteria for needing substance use treatment in the past year who actually received it. So that's about 1 in 4 people, or 24%, in that 12 or older age category. So that number is actually a bit higher. You'll see on another slide, 10% of people who meet the criteria for a substance use disorder. In the past, that's been typically talked about the population that has received treatment. But, in this 2022 survey found that that's up more. Again, reflecting partly the pandemic, maybe more availability of services, or more people recognizing and seeking out services, or understanding. We'll talk about insurance coverage too. But by comparison, this slide shows same survey, but the percentage who received treatment for any mental health or any mental illness in the past year, and that's over 50%. So the 4 bars on the left here refer to any mental illness, and then the ones on the right, serious mental illness. So you see, so for someone with a serious mental illness, the percentages for these different age groups are higher at above 60%, even 71% for that 50 and older age group. But by and large, the point here is to illustrate that, someone is more likely to receive treatment for a mental health challenge versus a substance use disorder. Any questions? I see one there. It has this number grown since COVID, especially for the 12 and older. So the 17.3% has been creeping up. There was also a change in how, it was determined that someone might have a substance use disorder. So over the years, that population has expanded, again, kind of reflecting some changes in how data is collected. But certainly, the 2022 data both reflects, what people were going through and how they answered that survey, as well as the data collection that happened. The question kind of, well, you said 12 and older, so that's the whole population, but certainly seeing higher increases too for, kind of young adults and adolescents. And this kind of, puts together some of those numbers, from the National Survey on Drug Use and Health. And the 2 questions at the bottom are thinking about, what we talked about previously, which is who might benefit from harm reduction education and services. And, the outer ring there reflects people who use drugs. That does include cannabis. And, that's in the past year, about 25% of the population aged 12 or older from that same survey, versus about 17% of the population with substance use disorders in the middle. So, thinking about harm reduction is an approach that, benefits the wider rings of this graphic here, versus as you move into kind of thinking about treatment, substance use disorders in the middle would be kind of a smaller subset of that overall population of people who use drugs. And in the middle there, that 17% does include alcohol as well. Any questions? So we also, talk about this phrase, the treatment gap, and that's what I referred to earlier, saying that national surveys typically report that just 10% of people with substance use disorders receive treatment, though that percentage has been higher recently. And again, comparing about half of people with mental illness receive some type of service for that. Removing barriers to treatment by offering treatment on demand and helping navigate insurance coverage, transportation, and other hurdles can help improve treatment access. And important to note that many people need other support beyond specialized treatment in order to recover from a substance use disorder or mental illness. Also important to note that some people with drug and alcohol problems achieve long-term stable recovery without formal treatment. And that, as we talked about with harm reduction, it's important to offer services if people aren't ready for or interested in treatment. So that's kind of setting up some of what we'll be talking about here. And, also want to show this, someone's asking about, AA, and I will get to that at the end of the workshop today, and other forms of mutual aid and peer support. So yeah, thanks for that question. Here is data, again, from that same survey that, historically is asked about locations where substance use treatment was received. They've kind of added that types and locations. So you can see that at the top, about 13.1 million people receive substance use treatment, and about 10 million of that was outpatient treatment. So even though sometimes we have this idea, we talked at the first session about what shapes our opinions about drug use, addiction, treatment, harm reduction, and recovery, the popular media, news, social media, personal experience, sometimes there can be this perception that residential or inpatient treatment is more common than it actually is. So, you see here, telehealth treatment, about 13.6 million people receive treatment that way in 2022. Inpatient, about 3.5 million. Medication-assisted treatment, or sometimes referred to, we'll talk about medications for opioid use disorder, that was about 2.5 million. And then medications for alcohol use disorder, 1.2 million, as well as, some form of treatment, whether that's in prison, jail, or a juvenile detention center, about 721,000. So often, when we talk about treatment, it ends up using language around where the treatment was received. Was it inpatient? Was it outpatient? Was it rehab? Was it intensive outpatient? So, today kind of trying to focus less on those locations and more on the services offered. But that survey also identifies a barrier that may be familiar to many of you working in this area. This is from the survey of perceptions of need for substance use treatment among adults age 18 or older with a past year substance use disorder who didn't receive treatment in that past year. So that's kind of a mouthful, but broadly, close to 95% didn't feel they needed treatment. And to unpack that, you have to think about, well, how are they interpreting that question? Did they have a mild substance use disorder? But it also captures that, people either due to negative perceptions about treatment, negative experiences with treatment, what's sometimes referred to as, denial or not recognizing that they might benefit from treatment, that's all in there as certainly a barrier to overcome. And this graphic kind of talks about some of the science around, some of the brain changes that can happen. This is from a report from 2018, Facing Addiction in America, just a graphic from the Surgeon General's report that year, but kind of identifying that, scientific evidence shows that disruptions in 3 areas of the brain influence the onset, development, and persistence of substance use disorders. So, the basal ganglia, the extended amygdala, and the prefrontal cortex. So you see sort of the areas that are impacted, that anticipation with the prefrontal cortex that's involved in decision making, this binge or intoxication, and then that withdrawal or negative affect that someone might experience. And this is where those, experiences are related to in terms of parts of the brain. But the disruptions, to kind of relate that to providers and what you might be dealing with is that, these disruptions can enable certain cues to trigger substance seeking. They reduce the sensitivity of brain systems involved in the experience of pleasure or reward and heighten activation of brain stress systems. They also reduce the functioning of brain executive control system. So that's involved in the ability to make decisions and regulate one's actions, emotions, and impulses. So I'm not going to go, too much into detail here. Everyone will get the slides, and, the links on these pages also go to more information. But, just illustrating that there are changes that happen that can affect, this willingness or recognition or of the need for treatment, as well as, other things like impulse control or emotions. Any questions? And this, I'm presenting again as a resource that might be helpful when you receive the slides, but you can't underestimate the impact of insurance and coverage and how people pay for treatment in our lifetimes. And certainly for me during most of my adulthood, this isn't something that insurance typically covered. Protections in federal law known as parity aim to ensure that most health insurance plans cover mental health and substance use disorders no less generously than coverage for other health conditions. Yet certainly people still encounter barriers to getting treatment covered, such as denials, limits on treatment length, prior authorization, and proof of medical necessity. So these are just a few guides that can be helpful if you're looking at, are interested in kind of exploring some of these intricacies of parity laws. And I've highlighted one here from SAMHSA that's a 2-page consumer guide that has some helpful resources and hotlines that people can call who are navigating that. But certainly paying for care and what's covered is part of that, barriers to overcome. So kind of opening back up to kind of discussion here, when we talked about harm reduction, I asked this questions, what are some concerns or hesitations you've heard about harm reduction? Hear that same question, not necessarily things you believe personally, but what's sort of out there? What are concerns or hesitations you've heard about treatment for substance use disorders?
Please feel free to use the raise hand function if you'd like to have your microphone enabled.
Yes, thank you, Kathy. Right, so, someone's posting about the medications for opioid use disorder. Some people believe that's, just as bad as using street substances. We'll be talking about that. That treatment programs, someone is writing, comparing that to jail or prison. Sometimes people have those punishing beliefs that the treatment programs aren't effective. So the question here is about treatment. I had asked a previously workshop about harm reduction. So yeah, that treatment sometimes doesn't deal with both mental health conditions, brain injuries as an example, and substance use at the same time or in the same program. Right. So how programs deal with, relapse or someone, continuing or returning to use while they're participating in treatment. And again, not enough support for mental health. So that's coming up certainly as a theme there. Yeah. So traditionally, not only have mental health and substance use care been outside the medical system, but then they're sort of separate from each other in many programs. And I see that in a comment there. Great, thank you for sharing. Yeah, mental health and substance use historically have been very separate, and getting kicked out of programs due to behaviors. Yeah, people might have caregiving responsibilities, whether that's a pet or, sometimes children, can be a barrier for someone who needs to provide care for those children. Um, Yeah, and the focus on acute care or fear of withdrawal. Great, thank you. So these are just, some of these have been mentioned, there can be a belief out that treatment doesn't work. It's difficult to evaluate success. If people have participated in whether it's a residential or an outpatient program, but then, return to use or other aspects of their life don't improve, sometimes that's perceived as, well, the treatment didn't work, why would I bother? Programs can be very punitive. So for example, discharging people for minor infractions or a single positive drug test, some changes happening on that front, but still, a barrier for many people. Not always available when someone is ready, finding treatment and being able to get there, as well as access to treatment, historically is based on income and insurance coverage. There can be reservations about offering medications for opioid use disorder, which has contributed to restrictions limiting access to these treatments. Programs can be too focused on abstinence as a universal goal, and services might not meet individual needs, especially for certain populations. Great, and seeing, some additional comments. Yeah, it's hard work, lack of transportation, the programs tend to be very short, or, insurance might limit how long someone can be or what they have to try first before trying a different program. Childcare is certainly a barrier. And, what's actually in part of the treatment program, which we're going to talk about, what could be on a menu, having that support system. So, what's in place for someone beyond treatment or in addition to treatment. Great. So, one of the things that's kind of a bit of a shift in the field is kind of this movement toward person-centered care. And this is, a graphic from a little animation from the World Health Organization that explains what that is broadly, but really thinking about, services being offered that they're tailored to people's needs and provided in partnership with them rather than simply given to them. And some of the principles of that are, that person-centered care respects the participant's own treatment and life goals rather than kind of dictating what those should be. That recognizing that it's an individual process that can vary among participants, understands that any positive change is a step toward greater well-being and health, offers services without judgment, avoids punitive policies. That doesn't necessarily not mean having any accountability, but some of those things people have talked about, rethinking, when someone might be discharged from a program. Emphasizes starting and continuing treatment despite any setbacks, and prioritizes culturally sensitive care with respect for participants' diverse identities and backgrounds. Yeah, and someone's mentioning, I mean, we'll be talking about a little bit about those family services. Um, yeah, and housing, someone's mentioned too, can be a real barrier. If how you address your substance use or mental health challenges if you don't have a stable place to live. Another aspect of care that's shifting is kind of really thinking about trauma-informed care. So trauma is used to describe experiences or situations that are emotionally painful and distressing and that can overwhelm someone's ability to cope. So trauma-informed care is characterized by understanding, recognizing, and responding to the effects of all types of trauma, emphasizing physical, psychological, and emotional safety, both for survivors and providers, and helps people rebuild a sense of control and empowerment. So in the first session, we talked about why people use substances. And, one of those reasons is kind of, to help deal with past trauma as well as other, experiences. So, in order to address the substance use, there's also often a need to address, the trauma or other conditions that people might be experiencing. And then on the right here, there's just examples of types of trauma, whether that's sexual, emotional, or physical abuse, might be witnessing the death of a loved one or violence towards someone, certainly incarceration, especially solitary confinement, not having your basic needs met, living in poverty, experiencing racism, misogyny, homophobia, transphobia, or other types of discrimination. And then negative experiences with systems and service providers, that can be part of the trauma that needs to be addressed during treatment. You may have heard of this explained as sort of adverse childhood experiences, sometimes referred to by the acronym ACEs, which are these stressful or traumatic events that occur between up to age 17. And, broadly, about 45% of children experience at least one ACE, and females and racial or ethnic minorities are at greater risk for experiencing four or more. So some of the potential effects of this, can be things like anxiety or panic attacks, withdrawal, insomnia, depression, suspicion of other people and institutions, sometimes feeling unsafe or threatened, anger, which can surface with providers, substance use, and potentially suicide. Also monitoring the chat here. So Kati, if you see anything, please let me know. These are some trauma-informed care techniques, so emphasizing emotional and physical safety. Really important to allow participants to disclose past trauma if and when they're ready, but it's safe to assume that anyone may have experienced trauma. Avoid blaming someone for their situation, protecting confidentiality, focusing on someone's strengths. Sometimes, when we start talking about some of the challenges and traumas that people have experienced, that can eclipse the fact that it takes, a lot of resourcefulness or resilience to deal with these situations. You might emphasize someone's loyalty to their community or the people around them. Emphasizing collaboration and choice, also part of that person-centered care. And acknowledging you may not understand someone's experience of trauma, as well as avoiding referrals or actions that may re-traumatize someone. So, making sure as much as possible that, referring to or providers or services that, will take more of a trauma-informed approach. Any questions?
Yes, we have one question that was shared in the Q&A pod.
I
The
think that
person
got copied.
asks, how do we best support a client who's using and unable to access shelter or transitional housing due to drug use? And the person has a client who is a heavy user and would like to get substance use assistance, but
Mhm.
doesn't have the stable housing. And this person feels pretty stuck.
Yes, a lot of that depends on sort of the community and policies, whether they're housing first policies or where you're located. New York City has a right to shelter, unlike many parts of the US. So, there are a lot of supportive housing options for people. I think, part of the harm reduction approach that we talked about is, one way to support someone who's navigating that, to, you know, potentially reduce the risks of their substance use until that housing can be addressed or that person is able to get into some kind of program. Often in those cases, a program that is a residential or inpatient program is necessary for someone who doesn't have stable housing if there aren't resources in the community that are kind of part of that housing first approach, where they would have a stable place to be as well as be able to participate in outpatient programs. And I welcome anyone who has other responses to answer those in the chat as well. Great. I think that question on ACEs, how to do an ACE test and explaining to a client without making them feel very discouraged. I believe there's a link on that page that, talks about resources and certain, ways to approach that. But, I think not asking directly, about past trauma, but asking kind of open-ended questions and, taking that time to build trust can help people feel more comfortable disclosing um, what you're kind of trying to get at as far as their past experiences, with trauma or adverse childhood experiences. And also there's a lot out there about this strength-based approach. So, not over focusing, and I see a suggestion here, YouTube video, thank you, too, that can be helpful with that, really balancing, talking about, the challenges with the strengths that someone is displaying or encourage recognition of that and celebrating kind of small successes too. So as we kind of get into goals of care or talking about different treatment options, this is just a review of something I showed, in a previous workshop is, thinking about goals of care for people with substance use disorders. On the left side, the ones that are substance related, we've talked about harm reduction and we'll be talking about treatment. Whereas, overall health might be about preventing overdose deaths and deaths from other causes, or addressing other physical and mental health challenges that might not, be related to substance use. And then on the right are these kind of broader functioning. So, the housing challenges someone might be experiencing, or connecting to legal or employment services, or providing support for recovery. So, just one way to think about goals of care more broadly. And then the next question here is kind of, if you thought about, treatment for a substance use disorder or substance use challenges, like a menu when we go into a restaurant, what would you include on a menu of specifically treatment services for people with substance use challenges? So moving away from that way of looking at it, was it inpatient or outpatient, residential, telehealth, but like what actual services would you put on a menu? And feel free to answer in the chat, as well as raise your hand if you're comfortable speaking. Yeah, so group services, group participation, as well as individual counseling, both in person and online, peer support, right? We'll be talking about all those. Educational groups, individual sessions, stage-based groups, stages of change is kind of an important underpinning therapy, great art therapy. I do a workshop at a harm reduction provider, focusing on art and storytelling, medical care, great, dealing with grief and loss, mindfulness activities. Yeah, if someone's in a residential or inpatient setting, time to get out into the community, meditation, great. So some ones that I haven't, I kind of put together this this menu, what's offered or missing. Great to see some additional things here, specific approaches, we'll be talking about CBT. But, if you think about a menu here, counseling and different mental health care approaches on the left, some of the group, individual, family therapy that have been mentioned, you might put case management, peer support, and mutual aid groups on that menu. In the middle is kind of more the medications and medical care. So, we'll talk about detox and withdrawal services, as well as these 3 medications for opioid use disorder. Someone might need other psychiatric medications or HIV and Hep C testing or treatment, wound care, and then broadly other medical and dental care. And then on the right are these kind of what I'm calling wraparound services here, legal aid, housing of help, employment assistance, educational programs, benefits navigation, aftercare and recovery support. So this is kind of a broad general way of starting to think about, a treatment menu and how that can be approached. And, sometimes detoxification can be kind of perceived as treatment when in reality, it's not considered treatment, but can be important part of the continuum of care. So what it is a medically supervised tapers from substance such as alcohol, benzodiazepines, or opioids. It's often provided in an inpatient setting. It may include medical and psychiatric assessments. Sometimes medications are offered for help with symptom relief, and importantly, provides monitoring during withdrawal. Some cautions about detox is that there can be high rates of return to substance use after detox, and there's an increased risk of overdose after detox due to someone's lower tolerance. So, ideally, any detox should include overdose prevention and naloxone training, as well as be followed by a longer care plan. And again, it's not considered treatment by itself, but can be part of that kind of continuum of care. As we kind of move on to talking about medications for opioid use disorder, just trying to get a sense of how familiar you are with those medications. 1 would be very familiar, 2 is somewhat familiar, and 3 would be not too familiar. Great. So this will be a review for some people, new for some people, and then, many people kind of in the middle. So, you know, I will kind of go over broadly, the 3 types here. So, this comes from a New England Journal of Medicine presentation. It's actually very, great thing to watch in full. It's a little description of the medications, but I like this graphic because it really, we talk about an agonist, methadone being an example, which means it fully occupies the opioid receptor in the brain. So you see that pink opioid receptor, whereas buprenorphine is what's considered a partial agonist. So, those little blue dots, it's partially occupying the opioid receptor. And then an antagonist, such as naltrexone, means that it's blocking the opioid receptor. So this graphic kind of is helpful in seeing and thinking about those distinctions and what those words agonist, partial agonist, and antagonist mean. So methadone, to start with, it has been around the longest. It's a medication that prevents withdrawal from opioids and relieves cravings. It is an opioid, so it's highly regulated by federal and state governments, and is typically only available in opioid treatment program settings, which can limit accessibility, especially in rural areas. Initially it has to be taken at a clinic every day. Take-home doses are usually allowed over time. Patients may be offered other services or required, such as counseling or group participation. And suddenly stopping methadone precipitates withdrawal. So, if someone is choosing to taper, that can take months, which would mean kind of reducing the dose over time. Buprenorphine is a medication that treats addiction to opioids like prescription painkillers and heroin by stopping withdrawal symptoms and reducing cravings. It is also an opioid. It's offered in different formulations, such as a tablet, a sublingual film, or more recently, an injection that can someone can get every 30 days or so. So they don't have to be taking something every day. Some of the brand names you may have heard include Suboxone, Sublocade, Brixadi, as well as other variations. And the difference between buprenorphine and methadone is that buprenorphine is available in various treatment settings, so including primary care, sometimes harm reduction programs as well. Importantly, combining buprenorphine with other opioids, alcohol or benzodiazepines, increases the risk of overdose, but it has a lower overdose risk compared to methadone. Yeah, someone's pointing out, sometimes people when they're getting off methadone, pointing out they have to go to detox facility due to withdrawal symptoms. Protocols can vary about that, particularly if a program, is tapering and kind of managing that, so it's not sudden. Naltrexone, also known as Vivitrol, is typically given as a long-acting intramuscular injection every 28 days. There's also an oral or a tablet version. It's not an opioid, so it can be an option if someone prefers to avoid opioids like methadone or buprenorphine. It blocks the effect of opioids, as that graphic showed, and can also be used to treat alcohol use disorder. Someone must not use any opioids for 7 days roughly prior to starting naltrexone. So, that can be a barrier for some people, and how that, period is handled and what support they get. And there is an increased risk of overdose when naltrexone wears off or is stopped. So again, kind of overdose education and providing naloxone is really important. What questions or comments, maybe experiences you've had or heard about from the people you work with, do you have about medications for opioid use disorder? Any questions? I'm going to talk a little bit more about kind of the benefits and limitations of these medications. Yeah, some facilities will not accept people who are taking these medications, so that might be, a residential program that is, that's shifting a lot, the availability within that program, and, some federal efforts too to kind of provide those options. Great. So feel free to kind of keep adding here. So, some of the myths about medications for opioid use disorder, these were mentioned early. Treating a person with medication for opioid use disorder is not, substituting one addiction for another. It can provide an alternative to what is increasingly, a very risky street drug supply. So is, an option for people who, want to control that cycle of cravings that they may be experiencing. Taking these medications doesn't mean that someone has less willpower or is less able to function. It's not a sign of weakness or failure if someone chooses to continue medication long term, so they shouldn't be pressured to quit or taper. At the same time, if that is someone's preference, important to respect that as an option and a choice. And certainly taking medication for opioid use disorder does not mean someone is not in recovery. That can be a perceptions out there, in certain settings, and really lots of effort to kind of try to change that. Important too to kind of understand, managing managing expectations with medications for opioid use disorder. And, on the left here are some of the benefits that it improves the control of, that cycle of craving and withdrawal. Research shows that they can decrease overdose and all-cause mortality, reduce illicit drug use and injection drug use, can help people stabilize emotions and behaviors, enhancing their ability to engage with psychosocial and medical services, and helps individuals regain the ability to participate in communities, families, and workplaces. Some of the limitations are, that specifically buprenorphine and methadone address opioid use, including heroin and fentanyl, but not other substances like cocaine, methamphetamines, those stimulants or alcohol. So, these are medications for opioid use, but as we talked about, with polysubstance use becoming, the norm or more common, often people need additional services for help with other substances they may be using. And thinking back about that menu or goals of care, medications target substance use, but many people need wraparound services and support to help address other challenges, including kind of mental health challenges they might be dealing with. And use of medications does tend to decrease over time. So, there's a lot of research, to try to address what some of the hurdles are with that. And someone's asking what services are available for people who want, to get in on a pathway to recovery without medications for opioid use disorder. I'm going to talk about some approaches. Great. And this slide just kind of shows, some efforts to increase access to medications for opioid use disorder. So, the federal government last year dropped a requirement that, providers had to apply for a waiver in order to be able to prescribe them. So that's expanded access. It can still be challenging to find a provider who can prescribe buprenorphine or dispense methadone, especially in rural areas. Research has found that urban residents are more likely than rural residents to receive medications for opioid use disorder in both outpatient and inpatient settings. And rural residents are more likely to receive buprenorphine than methadone, partly because of that, with methadone need often to start with daily dosing. Mobile units and telehealth, which we've talked about in earlier sessions, can help people connect to providers. And nurse practitioners and physician assistants are also allowed to prescribe buprenorphine, so that has also helped increase access. And you can see here, the link to the SAMHSA buprenorphine practitioner locator, where, someone can put in their zip or address to find contact information for nearby providers. This came out recently and was kind of interesting, that just shows that eliminating the waiver requirement, the number of people, practitioners who can prescribe buprenorphine increased, 27% to a little over 53,000 providers. So this is, nationwide. The number of patients who initiated buprenorphine treatment increased modestly. So the number of patients using buprenorphine increased a little over 2% to, just over 830,000. So, the conclusion from this research study was that these findings suggest that the policy may have reduced barriers to prescribing, but was insufficient to meaningfully increase buprenorphine use through the end of 2023. So other research has kind of pointed out that just the availability of providers doesn't necessarily overcome some of the payment hurdles, transportation hurdles, insurance coverage that people might have, or interest in these medications. So, there's a lot of effort to kind of expand access, but also important to kind of continue research looking at like participants' experiences, either taking these medications or trying to get them, or, what alternatives are available. Any questions? I'm going to move into kind of talking about an approach for stimulant use disorders. But we'll also have time hopefully at the end, but, want to also present a little bit about contingency management as a treatment for stimulant use disorder. So trying to get a sense of how familiar people are with that. Great, so a range of responses here, but a little more on the somewhat or not too familiar. So, partly that's, wanted to include that. So broadly, contingency management, it's kind of a formal name, but it's a type of therapy that offers rewards to participants who meet a treatment goal using positive reinforcement to motivate behavior change. So when used as a treatment for stimulant use disorders, participants are tested for drugs on a regular basis and immediately rewarded with a small incentive like a gift card or prize if they test negative for stimulants like cocaine or methamphetamine. So this reward increases over time for continued negative drug tests. So, maybe the reward starts at $10 and increases by $1.50 per week. A drug test indicating stimulant use that week doesn't result in punishment. It just means the reward isn't offered. Then it resets to the initial value at the next negative task, returning to the higher rate after continued negative tests. So different way of thinking about, not shaming someone, if they have a positive drug test. And it's also only testing for stimulants. So, this is a very focused intervention, for stimulants and not looking at opioids. So abstinence from all substances is usually not required. And this is just kind of some philosophy, why use rewards instead of punishment? Typically people respond better to positive reinforcement instead of punishment. So research has found that the reward doesn't have to be large to incentivize behavior change. And some of that comes through, the other participants in the program kind of supporting each other. Punishment doesn't usually teach a new behavior. It kind of focuses on what not to do. And it can have negative side effects like reduced self-esteem. Whereas positive reinforcement teaches new behaviors in a way that builds self-esteem and self-efficacy. And it can help contribute to a positive therapeutic relationship, motivating people to continue with treatment. There's a big kind of effort taking place in California, which is one, really testing the outcome of contingency management and making it more broadly accessible there. A couple links here where you can learn more, and then I have some others on a future page. And, this came out recently too, showing that, the availability of contingency management as a treatment is still somewhat limited. So, you can see the drive time to the nearest program in these states. So, the darker areas would be sort of longer drive time and, lighter areas, shorter drive time. So, that's kind of certainly impacting availability as well as some restrictions
One
on
second.
payments. Yeah, Brian, I see you have a question. Go ahead. Do you want to unmute? Brian, I see you have your hand up. Oh, took the hand down.
Wait,
Okay.
no. Hello?
Oh, okay. Go
Yeah.
ahead.
Yeah.
Oh, Ryan, if you have a question, maybe if you want to post it in the chat or try again. So this is a pretty short overview, but I, wanted to add these resources. One is, this is an opinion article in the Washington Post, but really long and, helpful kind of what I would say is like explanation of contingency management for the general public. Pretty detailed, links to lots of resources, certainly recommend that, as well as some of these other, links that just kind of go to resources both from the US Department of Health and Human Services, and then other places to kind of get more training specifically about that. So just wanted to share that. Any questions? And just a reminder, you will all receive copies of the slides. Another approach that's, maybe familiar to many of you, working in mental health areas, is cognitive behavioral therapy. For those less familiar, this is just going to be sort of a broad overview, but, it's based on the idea that the way someone thinks and feels affects the way they behave. So the goal of treatment is to help people identify, challenge, and change unhelpful thought patterns in order to change their responses to difficult situations. So again, thinking back about, why people turn to drugs and alcohol and, some of those behavior patterns, trying to, teach new ways of coping with certain situations. So, they teach CBT can help people with substance use disorders by addressing some of the reasons they drink or use drugs, like anxiety, anger, stress, relationship problems, or other challenges that negatively affect mental health and quality of life. So, they target what's sometimes referred to as these irrational thought patterns that can negatively affect behavior. So, that might be all or nothing thinking, seeing everything in black and white terms and ignoring the nuance or complexity of a situation, catastrophizing, assuming the worst will happen, and personalization, believing that you're responsible for things that happen around you, overlooking other factors. Um, these are a couple resources that, give more background about that, for people who aren't familiar with CBT. But this comes from a research study that, kind of gives an example of how these kind of negative thoughts or behavioral habits can make people feel bad about themselves. This isn't related to substance use, but an example that can kind of help illustrate, if you see somebody on the street and say hello, but they don't say hello back, your reaction might depend on how you assess the situation. So here on the harmful side, you might think, he ignored me, he doesn't like me anymore. That might make you then feel down or sad or rejected. And then the consequences is the behavior, avoiding that person in the future, even though the assumption could be completely false. Whereas a neutral approach might be, that person didn't notice me, maybe he doesn't feel well. I should give him a call and find out how he's doing. These thought patterns don't cause any negative feelings. And then the thought might be a prompt to get back in touch with the person and find out if everything is all right. So I see someone's kind of adding in the chat, reframing your thinking. If you think about, social media and what people, particularly young adults are exposed to, and kind of how that can, create this or triangle between thoughts, feelings, and behaviors, or just other situations. So CBT has been around for a long time and, definitely used as an approach to substance use, that can be on that, menu of care, for people with substance use disorders. Any questions, comments? So this is kind of, I'm going to show some resources, for where to find treatment options and, questions to consider when referring people to treatment for substance use disorders. If there's a program that meets all of these things, that's probably rare, but even though it's an ideal, it's kind of a good set of questions to think about. Does the program fit the person's needs and goals? That person-centered care, how soon can treatment start? What insurance is accepted? What are the costs? What are the hours and flexibility of the program? For outpatient services, someone may work or have, childcare responsibilities or other caregiving responsibilities they need to work around. What medications are available for either opioid or alcohol use disorder? What mental health services are available? Is there individual or group counseling? Someone might have a preference for one or the other. What other health care services are available? And then on the right, there's, is help offered for, things like childcare, transportation, benefits and medical coverage, help for specific populations, that might be LGBTQ plus, veterans, pregnant clients, et cetera. What type of ongoing care, aftercare is offered, as well as these other, help with housing, employment, education or training, and legal services. And again, this is kind of an ideal, but certainly things to kind of think about based on, the person and what their individual needs and preferences are. So another question here is kind of, what experiences you've had connecting clients or participants with substance use treatment services, if that's not something, you particularly offer in your own work, what has been helpful or challenging? Kind of connecting people you work with to programs specifically for substance use. And again, feel free to raise your hand and, we'll unmute. Yeah, clients not following through with recommendations, so there can be a lot of reasons for that, including that, you know, statistic at the beginning, 95% feel they don't need treatment. Yeah, no childcare or transportation, insurance not covering needed services. Follow through. Great, someone who works on the 988 hotline. We've talked about that in earlier sessions. Client being stipulated, so that might mean, if I'm reading that correctly, mandated to a specific type of service or services in general that they may not feel are needed or that they want. Pet care, again, not having support from their personal networks, family and friends, wait lists. Issues with medications or not having services for certain populations. Yeah, how do you work with or address the fact that they don't feel they need services? There's whole trainings that are, I mean, I would say that motivational interviewing, if you haven't had experience with that, is great way to kind of learn about conversational techniques and asking open-ended questions and kind of identifying the thing that might motivate them to consider, it's historically been used with substance use, but, can also broadly be used with other behavior change. It's sort of a conversational technique that can be helpful. So if you Google or look for training on motivational interviewing, that's one approach that can help. Qualifications at the treatment program. They've already had treatment and failed, I'm just reading from the chat here, or, maybe the treatment was a great program, but they needed other aftercare or wraparound services. Great. Thank you for these responses. Yeah, overlap with, you know, the legal system, and, someone might feel they can't be open or honest because it might send them back to jail, or they need a higher level of care. So, just gonna quickly kind of go through some resources. Again, you'll get the slides. So, these are, to find national resources for substance use and mental health care, these are the ones, the federal government typically promotes. There's also one that, for people in or near these states, you may have heard of this treatment atlas from Shatterproof that I like to show just because, it puts a kind of different interface on finding treatment resources. And you can see the dark states of where it's available, meaning they list resources for those states, and, plan to continue expanding. But one of the things, that it allows is sort of doing a search where not only do you put in your location, the substances you or the person you're helping might be dealing with or interested in addressing, what types of services, as well as special programs. So someone, you could check off looking for a program for someone who's living with HIV or AIDS, or is a survivor of sexual abuse or domestic violence, maybe a program for veterans, someone who's pregnant, or, LGBTQ plus populations. You can also check off if someone is really, I need to go to a program that allows smoking or tobacco products, that's an option there too, as well as some of the other, things like childcare, transportation. And then on the right, being able to select, does the program offer these medications as well as mental health care or primary physical health care. So, whoops, just a good site to know about. Can I show the treatment list again? Was that the questions for the referrals? If you want to just clarify that questions. Yeah, and then level of care assessment is another one. I haven't included it today, but, going through, that level of care assessment, and, someone might not agree with what that concludes in terms of, where that referral might, recommend it or what type of care they need. So I don't know. Someone's here has posted that some clients have said they were honest and open during their assessment, and they felt like they had even more of a negative response pertaining to their level of care. So the government sites, so that these were, typically national resources for substance use and mental health care, but you will get these slides too. And then, because this is offered out of New Jersey and kind of overlap with New York, won't go over all of these, but, specifics resources for New Jersey, starting to see more hotlines in addition to the 988 hotline operated on the federal level that does refer people to local resources. I see someone participating today, works on that hotline. Some states also have hotlines. And, here the Mental Health Association in New Jersey has a peer recovery warm line, offered, it's a peer-based service, as well as, the New Jersey Suicide Prevention Hope Line. And then in New York, a couple, or one thing that's helpful to point out about New York, in addition to, the tools that the New York State Office of Addiction Services and Supports offers, there's also the New York State's CHAMP Ombudsman program, which helps patients and providers address insurance issues related to accessing substance use and mental health services. So that's a good resource to know about as well. Just checking out the chat here. Great. So, many of you may be familiar with peer support services. The last couple topics I'm going to talk about are peer support and mutual aid. But, if this isn't something you've kind of been exposed to, peer support can encompass a range of activities between people who share similar experiences of being diagnosed with mental health conditions, substance use disorders, or both. Provides a connection and inspires hope. So by sharing their own experience and practical guidance, peer support workers help people develop their own goals, create strategies for self-empowerment, and take concrete steps toward building fulfilling, self-determined lives. So, this link goes to a little bit more information about, peer support from SAMHSA. But broadly, some of the benefits of peer support, are this, helping increase someone's sense of hope or inspiration by seeing someone else who has, achieved goals related to their substance use or mental health. It can contribute to an increased sense of control and ability to bring about change in their lives. People tend to feel an increased sense of empathy and acceptance with someone who's been through that similar experience, a peer, and an increased sense that treatment is responsive and inclusive of your needs, as well as increasing social support and functioning. And, research has shown it can decrease substance use and depression. So, both through the funding streams and insurance reimbursement and training programs, much more effort to train and place peers in different settings, to help be that bridge to, substance use or services for people with substance use disorders as well as mental health challenges. And these are, typical peer support tasks. And, the person who's here, if you feel comfortable adding anything to the chat, or speaking, but, often conduct overdose prevention trainings with participants and their families, including naloxone distribution, helping motivate people with substance use disorders to enter treatment, engage with care, can address ambivalence about change, can help with referrals to treatment, rehabilitation, housing, and supportive services, and often work with different treatment teams to facilitate engagement with services. So, seeing them in places, sometimes including jails, often in emergency departments, a lot of communities kind of bringing peers into those roles through community-based organizations and other settings. And, this is a directory of state, what are known as recovery community organization, which is nonprofit led by people with direct lived experience with substance use challenges and recovery. So, that can also be a place to find out, not only about kind of peer options near you, but also training for people interested in peer support. What education, there are actually kind of training accreditations are different in different states. So, there's not necessarily an education requirement in terms of, a high school diploma or a college degree in that sense, but you do go through a training program. The length of it varies around the country. There's some effort to kind of standardize that. But, sometimes, and the number of hours of training can vary, but, usually you do that training and then have kind of some supervision, and then you get some kind of accreditation as a peer support specialist. The names can kind of vary in different areas as well. I'm just reading the chat here, and the peer support person can be seen, again, as a peer, not necessarily someone, in a position of authority or a clinician. Um, yeah, someone here is saying, I believe this is Rhode Island, also has a program called Safe Stations where any peers can go to a local fire department and be transported directly to treatment. Yeah, different places have some recreational activities, and sometimes those are just kind of organized things like, it might be a running group, might be a climbing group. I've seen that in Rochester, New York, different approaches, but I think increasingly there is a recognition that sometimes, exercise and recreational activities, can be part of that. Yeah, so someone's noting each state varies for certification, somewhere around 40 hours of in-person training along with 40 hours of additional independent courses. And then, you submit an application and usually typically go through testing. So, those numbers vary, but thank you for adding that. Any questions? Yeah, and then continued ethics training. So also wanted to kind of address mutual aid and recovery support. People have asked about that, and starting to be more research that really identifies some of the overlap between the components of what peer support and mutual aid can both offer. So this Faces and Voices of Recovery publishes a guide to, or on their website they have a guide to different types of recovery groups. So um, people seeking or in long-term recovery along with their families and loved ones have a growing number of mutual aid groups to participate in. Increasingly, partly coming out of that pandemic, you can find more options that are offered online as well as in person. And, this link goes to, 50 different groups with descriptions of each one and kind of a link to, where to find out more about, where they meet, and what their approach is. On the right here, it kind of explains three types of mutual help organizations. So, the most familiar tends to be the 12-step organizations like Alcoholics Anonymous, known as AA, or Narcotics Anonymous, NA. There's also more secular options that are, not 12-step. Smart Recovery, Women for Sobriety, and Life Ring are a few examples of that. And then there's some that are, more religious, such as Celebrate Recovery. So these links to go to, different listings where you can find out about those different groups. Great. And yes, definitely groups for people who are using medications for opioid use disorder or potentially alcohol use disorder, that, might overlap with 12-step, but be separate than, traditional 12-step programs. And, this kind of juxtaposes some research, back from 2004, as well as kind of more current ones that, identify features of mutual aid groups. So, thinking beyond just, is it AA or Smart Recovery or Life Ring, but, some of the common features are, members share a problem or status, that the leadership is self-directed, that it values experiential knowledge, so that lived experience. There's kind of a norm for reciprocal helping, so helping each other, that there isn't a charge, so really increasing accessibility, that it's a voluntary participation, recognizing that, there are and historically have been group or people who've been mandated to certain programs, and inclusion of some personal change goal. More recent research kind of, identifies a little more specifics here, bonding and support, goal direction, a structure, often following a sober lifestyle. That can mean different things, not necessarily abstinence. Available role models, those role models overlapping with peers that, offer that, hope that, if that person can achieve, the changes that they've made, maybe I can too. So, building self-confidence, developing coping skills, presence of similar individuals, and developing self-awareness, reflection skills. So, links to, more about both of those research papers that kind of identify, what's in common regardless of kind of the type of group. And this is kind of adapted from uh, this link at the bottom, a webinar, that presented evidence about mutual help groups. And, this is to help kind of think about how do you navigate referrals to these kind of recovery groups. So I mentioned motivational interviewing techniques, for conversations about peer support or mutual aid. So, one would be asking about their experiences with mutual aid or peer support, you know, asking if they're interested in learning about directories that list groups and meeting options, and then sharing those resources. Discussing whether their goals are compatible with a particular group. So that might be abstinence, but it may also be moderation or harm reduction. Um, Exploring hesitations about participating in groups. Someone might be concerned about privacy, if they're going to an in-person location or even sometimes online, being recognized, and then what the consequences might be for that person, particularly in communities where everyone knows each other or most people know each other. You know, might be some hesitations based on one's gender, race or ethnicity, religion or spirituality. Can be a perception that certain types of groups are more spiritual or religious. So kind of exploring those hesitations and, certainly supporting the choice not to attend any group. Um, and, some of these questions I think are interesting, to kind of help people identify, if peers or mutual aid are maybe an option for them, is kind of asking, who do you feel comfortable in your life talking to about your drug or alcohol use? When is the last time you told someone about your current substance use or your history or goals? And then kind of more generally, how do you learn coping skills? Sometimes those are an important part of what's shared during these groups. And, what role models or examples of success have you seen up close? So, thought these were kind of some helpful questions to think about, and, feel free to share in the chat, or if you're comfortable talking, you can raise your hand. Someone's recommending if you have the ability to make referrals for peer support, do. Great, focusing on strengths-based relationship of mutuality, which allows the participant to lead their recovery. Sorry, it's bouncing. Um, yeah, and also that mentioning that kind of providing warm introductions to community resources. So, if you've heard that phrase warm handoff, it's often, peers in that role and other service providers too, as opposed to just handing someone a list or a link to a website or a provider directory. Warm handoff is really helping them navigate actually getting there. In some places I've seen, peers might physically drive someone, or accompany them, public transit or however that is, or help them overcome some of the hurdles to accessing, these programs or services. So great, thank you for sharing that. Someone's asking, is group better virtually or in person? My response would be, it really depends on the individual and their preferences. We're all here today virtually, and part of that allows us to overcome, barriers that if this were offered in person, most of you wouldn't be able to get there, people from around the country, or it just means, even if you were in New York, taking time off the transit. So, that's the same with, whether it's mental health care, a lot more offered virtually these days. But some people prefer that in-person experience. You in these mutual aid organizations or groups, you have those conversations before or after the group or during the group. And some people might feel that that is actually more private than something that's shared online. Yeah, so seeing different responses there. Yeah, someone mentioning a case management role taught me that without a warm handoff, many folks fall off and don't engage with the referrals. Yeah, for in person for some people, but if you have social anxiety or certain phobias or just distance, virtual is a great option. Yeah, and I think people kind of either know their preferences or they can try one or the other, and they're not necessarily mutually exclusive. I know people who do some in-person things and some virtual things. So great. So we're coming up on the time here. I'm going to show or Kati is going to show and talk about links to a couple surveys here, but feel free to ask any questions in the chat, and raise your hand, and if you have something you want to share or speak, that's an option too. Kati, do you want to talk about this training?
Yes, thank you so much, Susan, for providing us with a wealth of information in your webinar today. And thank you everyone for participating so actively in the chat. It was really unique to see so much input and participation and sharing experiences. So as part of our funding, as mentioned before, we are required to have all of our training programs and services evaluated. And if you could please take a moment to complete a short evaluation survey, I will share the link again in the chat box. Or you can also access the survey through the QR code that you see on your screen. You can use your handheld device and scan it, and it'll take you directly to our survey. Next slide, please. Also, we want to share with you another survey opportunity. We are conducting a survey to increase the understanding of the experience, knowledge, and attitudes and perceived needs of mental health providers in delivering services and supports to individuals who are blind or visually impaired. Your participation, of course, is anonymous, and the participation in the study involves the completion of a short 15-minute survey, which qualifies you via raffle to win a $25 Amazon gift card, not paid for with grant funding. So I just wanted to make that also known to you. Also, if you have any questions, please feel free to contact our center. You can go to the next slide, please. And you can reach us at Northeast Caribbean at mhttcnetwork.org. As a reminder, we will post the recording of this webinar on our website within 7 days, as well as the presenter slides, and you will also receive a link to download your certificate to your email, the email that you registered today for this webinar. Next slide, please. We also invite you to join our listserv so that you can receive an email announcement such as our newsletters or any webinar flyers and announcements. So I will also put the link in the chat. That's easier for you. Susan, do you have any additional comments? Or I just also wanted to let everyone know that they can stay on for these additional 2 minutes. I will pause the recording at this time in case anyone wanted to have their microphone enabled.